We have a lot of objectives when we treat a hip fracture on the elderly, but two of the most important for me are to avoid complications and to try to return the patient to the previous functional status. For this, it's very important an accurate postoperative care based on rehabilitation protocols to achieve an early mobilization and ambulation. But what do we really know about the benefits of an early ambulation? I will present a couple of studies. That's the first one. By Old Meadow, that's a randomized controlled trial. They compared two groups. The first group with patients who were allowed to full weight bearing the first or the second day after the surgery. And the second group with patients who were allowed to full weight bearing after 3 or 4 days after the surgery. They didn't compare any other variables, such as the type of fracture, the age, complications, mortality. They only compared this, and they obtained a less hospitalization time and early function recovery, a faster early function recovery in a very short term in the first group, the group with patients who were allowed to a full weight bearing ambulation the first or the second day after the surgery. The second paper is this review from the Cochrane, which studied different aspects of the rehabilitation protocols, like the time to weight bearing, muscle strengthening, electrostimulation, and they conclude that we think that there's a positive effect of an early ambulation, but we don't know yet how can we achieve this effect. The protocols are not really, there is not a consensus between protocols, and we cannot be sure until today that how we can achieve the positive effect that an early ambulation has. We as surgeons normally do not have problems when treating stable fractures. I think that in my case, and I think all cases, very stable fractures, we allow the patients to have full weight bearing. But what happens with those fractures, those unstable fractures? We can act in the same way in stable and unstable fractures. There's a big controversy in those unstable fractures. That's why we started this review last year during my fellowship here in Instabile, and those are the study questions. Which are the rehabilitation protocols reported in terms of allowing or not full weight bearing to our patients? There is any restriction depending on the reduction? There are any benefit or less complications of unrestricted weight bearing? Our inclusion criteria were patients over 65-year-old with unstable fracture treated with nails, and as exclusion criteria, other treatment than nails and previous pathology in the broken hip. We analyzed different variables, those in the slide of the final number of papers. And after reviewing PubMed, Medline, and Cochrane Library, we obtained a sample of more than 7,000 articles, starting on 1948. First, we deleted the duplicates and then selected only papers written in English, German, and Spanish. Then we applied our inclusion and exclusion criteria, and finally, our sample was of 15 papers, which sum up more than 1,500 patients with a mean age of 70 years. And a minimum follow-up of 1 year. Let's go back to the study questions. What do we have until now about rehabilitation protocols reported? I've done those two tables, that's more easy, depending on restrictions of the weight bearing. On the left, the authors who put some restrictions or didn't allow their patients to a full weight bearing, 7 authors, and on the right, 8 authors with non-weight bearing restrictions. As you can see, there's a variety on the opinions on the authors. Those are fragments of different papers. All these papers are on the left group with weight bearing restrictions. That's only to show the diversity of the protocols. For example, partial weight bearing after 10 days between 2nd and 8th week, partial weight bearing of approximately 30% of the weight of the patient, or partial or no weight bearing, depending on the surgeon's opinion. Regarding to the second question, in this table we can see the 2 parameters that all the authors used to assess the reduction obtained on the surgery room, the tip to apex distance and deep Baumgartner criteria. Both results are correct under 25, in tip to apex distance, we can see some differences, but it's important to mark that on the weight-bearing restriction group, there was only one study using this tip to apex distance, while in the right group, there were 6 studies using the tip to apex distance. Any of the authors did any changes on their protocols depending on the reduction obtained on the OR. The third question, there is any benefit of unrestricted weight bearing? As we have seen on the first paper by Old Meadow, in our review, we also obtained the same result. The group of non-weight bearing restriction obtained a less hospitalization time. Regarding the functional outcomes, 8 different scores has been used by the authors. 8, the Harris Hip score, the Bartel, SF36, Eurocool, very variety of scores. The Harris Hip scores was the most used by 8 authors, but only 5 used it after 1 year of the surgery. And the last one, what about complication? It can be expected less complications of unrestricted weight bearing. Well, while regarding orthopedic complications and mortality rate, we obtain similar numbers. The astonishing finding was the huge difference regarding systemic complications between both groups. One possible explanation is that only 5 authors of the 15 reported medical complications. Of those 5 authors, only 2 reported an accurate analysis of the medical complication. The rest of the authors only considered some of the complications, for example, the need for blood transfusion. All those 2 papers who did an accurate analysis of the systemic complications were included on the non-weight bearing restriction group, and they obtained up to 50% of clinical complication. That's probably the explanation of this huge difference. There are another publications on the literature with a similar rate of systemic complications, up to 50%. And finally, as a strength of the study, that's the first review of a specific unstable fracture with more than 7,000 papers, and as the limitations, as said before, the big heterogeneity and variety of studies, which makes very difficult to compare results and to extrapolate those results to our daily clinical practice. As a conclusion, we can say that there is no consensus on rehabilitation protocols in unstable femoral fractures on the elderly. We need randomized controlled trials comparing those different protocols using standardized scores and the collaboration between professionals, physiotherapists, orthopedic surgeons, geriatricians is mandatory.